Start our recording, and if you don't mind, just as a way of getting started, because we have a small group and because the wonderful speaker that I have today could be able to tailor some of the comments based upon who we are speaking to. We have a really small group here. So what I want to do is just really quickly give each person an opportunity to share just your name and the organization that you work with. And then we're going to get into the content. For those who do not know me, my name is Carlton Hall. I am the founding president of Carlton Hall Consulting. You can tell we worked long and hard to try to figure out what to name this company. But I am grateful for the opportunity of working in the field of prevention for more than 25 plus years, and had a great opportunity of doing that across the nation, as well as within your state. So I know much of the work that you all do pretty well, and I'm very honored to be able to have this opportunity to be with you all. We're going to get an opportunity to introduce the rest of our team, but I'd love to hear who is with us today. So I'm going to start off with Ms. Dion. Hey, Dion, would you mind?
Hi, good morning, everyone. Thank you, Carlton. I'm Dion Cornish with Brandywine Counseling and Community Services in Wilmington, Delaware, and I've been with this organization since 2011.
Extraordinary. Thank you so much, Dion. Hey, Maddie.
Hi, Carlton. I'm Maddie. I work for Joseph Hughes, and we are contracted with the SPF Rx grant.
Thanks so much. Give Joe my best.
Thank you.
Hi, Kathy.
There we go.
There you
Sorry.
go. There you go.
There, I had some glitches going on.
Good.
I am Kathy Jo Robbins. I am with the Delaware Health Insurance Help and Services Office of Health Crisis Response, and this is our first with the SPF Rx. So this one's new to me, but we've been working on the some other grants, and I have been here with OHCR since December.
Glad to have you here. Glad to have you.
Thank you.
Hello, Ms. Clark. How are you?
Hi, I'm Ann Hiller Clark. I'm from the Division of Libraries, and previously I was the director of the DHSS library, so I'm interested in health literacy.
Wonderful, wonderful. I'm excited for the conversation that we're going to have today with you. And my wonderful, wonderful friend, Dana Holtz. Hey, Dana.
Carlton, nice to see you again.
Likewise.
My name is Dana Holtz. I'm with the Center for Drug and Health Studies at University of Delaware, and I work as part of the evaluation team for the SPF Rx.
Beautiful. Thank you so much for being here. And hi, Yvonne. How are you, my dear friend?
Oh, I'm great on this Friday. Happy Friday. I'm Yvonne Bunch with the Division of Prevention and Behavioral Health Services. I manage the prevention set aside of the block grant, extended hours. I do a little bit of everything. But glad to be here with the group on a Friday.
I'm really grateful, and I'm actually grateful that we are here and that we actually do have a more intimate kind of setting today, so that we might be able to have probably a more in-depth conversation that we want to have today. So what I'm going to do is I'm going to share my screen, and I'm going to warn folks. Dave, you can let me know if I'm still coming across and you guys can still hear me. Can you hear me well?
I can.
Fantastic. Fantastic. So hold on one second. Excuse me. My computer is acting a little crazy today. Come on now. There you do. Work with me, honey. Work with me. Dave, can you see my screen?
Yes, we can see it.
Terrific, terrific. So today we're having a conversation. It's entitled Media and Literacy. And what it really is about is it's really about how do we think differently? What are some of the best practices that we can put in place when dealing with trying to engage underserved communities Black, Indigenous, and communities of color, communities where the approaches that we've typically done with respect to prevention science and the work that we do in our health fields are often not as effective as we want them to be. And so I'm really looking forward to it because I'm grateful for the partnering that I have with the gentleman that will be leading most of the conversation that we have today. We are going to be conducting this in a way that we hope that it can be interactive and engaging for everyone. In the midst of delivering this, I have my great friend Dave Clausen, who is a prevention leader in his own right. He oversees the Mid-America Prevention Technology Transfer Center, and he's been doing that since its inception. He is so he's knowledgeable about our work in our field, but he also happens to work and partner with me with respect to delivering these kind of training events. So he is our tech guru behind the scenes. And Dave, I think everybody here is pretty much really savvy with kind of the Zoom apparatus and setup, but Dave will be engaging with you all through the chat box to make sure that we're actually to have a conversation. And so with that, I'm going to share with you that we are doing this in partnership with the Division of Substance Abuse and Mental Health, and also our wonderful friends at the Children's Department. Yvonne, thank you so much for being here as well. So Maddie and Yvonne, thank you so very, very much. Maddie, I didn't know if there was anything that you wanted to share on behalf of Joe with respect to this, but if so, if there's any comments that you'd like to offer at this time, I want to give the opportunity to you to do so.
I don't have any comments at this time. I do believe Joe, he's in a meeting until 10:30, so he might have more additional information. He might pop on in about 30 minutes, maybe.
Not a problem whatsoever. Not a problem at all. Thank you so much for being here, though.
Thank you.
So want to share with everybody that this is being recorded. Our great thanks to everyone that made it possible for us to be here, because I never quite know where all the right resources are coming from with respect to these kind of events. We just want you to note that the views that are being expressed do not necessarily represent the views, policies, and positions of either the Substance Abuse and Mental Health Services Administration, SAMHSA, or DSAMH in the state of Delaware. That being said, so they're all off the hook for anything that we say from this point forward, and we can get into some really good information that I think we have to do. So, sorry, I told you my computer is acting silly. Come on now. Let's see. There you go. Oh, I promise you, there you go. This will get better once I get off this screen. I am so grateful to be able to have one of our partners, a colleague and someone who has become a really dear and close friend, not only professionally, but also personally. We found that we shared a vision for wanting to make some real impactful change on behalf of communities that are often underserved. And his application of science and rigor to how do we do that best for these communities is something that really came to light for me. And I wanted to ensure that we were able to provide some opportunity to share that valuable information to as many folks as possible. And so I'm grateful to have Ivan Juzang, who is the founder and president of Me Productions. Me Productions, motivational, educational, and entertainment, is actually a market research, health communication, and social marketing firm that specializes in culturally relevant behavior messages for hard to reach, low income, and underserved audiences. Ivan has some degrees, one from Carnegie Mellon University, and he created me during his final year at the Wharton Graduate School, University of Pennsylvania. He gained national prominence for their primary research study, the Me Report, that is reaching the hip hop generation. And over the years, Ivan has helped the mental health and public health agencies across the nation engage in how they might be able to affect and impact low-income communities and youth that are affected by the issues and challenges that we are all trying to pay attention to. And so he will be coming up in just a moment, but I wanted to share this thought with you as we do this. Most of us that are on this call and are on this call or on this webinar rather, as a result of participating in the state's efforts to mitigate the issues and the harms associated with substance misuse, primarily the opioid challenges that the entire nation has been facing, but that funding has been applied towards how might we be able to build the capacity of our communities to address this. And so we have been utilizing the tools of prevention science and primarily a public health model approach in doing that. And many of you on this webinar are very familiar with that public health model approach that we've been providing, right? We've been really good at building the capacity of our communities to understand the importance of defining the issue and defining the problem. And through the work and the tools of prevention science, identifying risk and protective factors and the context in which those things play out within our environment, and how to think concretely about evidence-based, proven and tested strategies that we might be able to apply in a comprehensive manner, right? We have been trained in that. We have been employing those tools, and that's part of what the resources and the funding that the state has offered has really been geared towards trying to get us to do. A lot of our training has been around that. But there is a fourth step to this public health approach. And that fourth step, I think, is where the rubber really meets the road. It's really what makes all of this work and all of this impactful. And that fourth step is assuring the widespread adoption of that prevention science. And this is where we've had some issues and some challenges, right? Particularly in some of the most vulnerable communities within our service area. And so that's what this conversation really is going to be about today. And with that, I'm going to stop sharing my screen. And as I tried to do my best in introducing Ivan Juzang, who will take us forward in this conversation, he's going to apply and share with us tools, information, research that he and his company has done that I found has been extraordinarily effective across the nation, and I think is an important tool and resource for our prevention field. And so with that, Ivan, I'm going to stop because I'm looking like max headroom now because of my internet connection, and I'm going to allow you to come and go and take us forward. So thank you all very, very much for enduring that.
Okay, everyone see the screen? Am I all right? Okay, good. Thanks, Dave.
You're good.
Appreciate it. So, yeah, I was really happy to hear the introductions. I think there's a lot of overlap. Just listening to your descriptions and your titles. Me Productions, just so everyone knows, we basically are a health communications ad agency. So our business model is to function as an ad agency, right? Clients call, engage us to do campaigns, but we really have evolved more into a health communications company that focuses on exactly what Carlton said. Prevention is the primary focus. And the reason why is because we're working in the lowest income communities that have the highest health disparities. A treatment model by itself isn't going to ultimately help you get upstream. You'll just be, you'll just be fishing folks out. The second thing about a prevention model, it really addresses multiple health disparities. So it's kind of the only way you can ultimately try to really start making progress in communities is because you're actually focusing on not just, in a silo. Obviously, we have to deal with alcohol, tobacco, but if you're really doing primary prevention work, you're actually dealing with suicide, you're dealing with youth violence, you're dealing with child abuse, you're literally, so we have to understand that. And so what my company does is, for the last 30 years, is we do really population health interventions, like Carlton said, widespread. So we're targeting, we're working with health departments, primarily health and mental health departments at the state level, and we're really helping them figure out how to, in the best way, implement social marketing campaigns. So I'm gonna, in a very open way, I'm just going to tell you guys how we do things. And the reason why I want to share it that way is because it's just a frame that you can use to say, how do I really want to do prevention work? Also, how do you do prevention work in a time where you have to get more with less? I mean, we have to figure out ways to be the most effective with the resources that we have. This is not only the most cost-effective way, it's actually the most culturally competent and culturally relevant. So I'm just going to take you guys through just an hour. We can make it interactive, but I'm just going to go through the slides. The slides will be obviously available to you. All you have to do technically is, you don't even need the slides. You just need to, if you want to take notes, just write on one piece of paper, this SMCR. And if you write in SMCR, you'll be able to take the whole notes for the conversation and literally have the model that we use on a piece of paper. So we're gonna just take you through how we approach the work that we do. So a lot of this is health literacy. It's all strategic prevention framework. We just have a different take on the SAMHSA model. It's all around not only prevention, but also crisis. As I mentioned, someone said in their name, it's about what do we have to teach, or not really teach, that's the wrong word. What do we have to, how do we have to educate and put skills in the community that help the community deal with the moment of a crisis? Literally, stress and trauma is so much that it's not if it's going to happen, it's when it's going to happen. Right? We're not thinking this, we're not thinking that, oh, this is trauma once a quarter, 3-4 times a year. I'm almost 60 years old. I've had 3 traumatic episodes in my whole life. Death of my parents and a divorce. This is happening 3 times a year, 3-4 times a year, particularly for urban, low income, even low income rural. Our work in rural communities, same thing. People think that it's just an urban issue. It's poverty, then followed by race. But we'll get into all that. But anyway, so if you just want to take notes, sender message channel receiver, even though you'll get the whole set of slides. So again, so my company does what we call behavior health interventions, right? So it's really, like Carlton said, the colliding of basically communications, i.e. communication/marketing, psychology, and then, as Carlton said, the best evidence-based science. What's the science behind it? The psychology is key because it's a behavior change. The second thing I want everyone to know is we only work in communities that have the highest health disparities. That's just our mission. So we only take contracts or grants or engagements that focus on hard to reach communities with the highest health disparities. And the reason why I want to mention that is because people always need to understand, if you have a high health disparity, you have a very high level of mistrust. And rightly so, actually. So if you have health disparities, the community doesn't trust government, any form of government, any form of mainstream institutions. and primarily not because they don't want to trust them, that they've been mistreated. And so you have to understand why the mistrust is there. It's there because of treatment, not because they can't access it. It's how they're treated when they get there. So then you treat people bad, they're not going to trust you over time. And so you're doing interventions that not only have to deal with the health disparities, but also have to deal with the mistrust. So I mean, you can't even list all the health disparities. These are the disparities I've been working on since the beginning. So a lot of sexual reproductive health, still a major issue, still a major health disparity when you look at sexual reproductive health in our communities. HIV, been dealing with, we'll talk about our substance abuse work because, I've straddled two areas of this issue. I've only done substance abuse prevention or just prevention overall, and I've only done it on the prevention side, but you have to realize, we'll talk about this. I was, and Carlton as well, for a number of years, my first 2 decades, I was primarily working in the framework of the war on drugs. Last 10 years, it shifted to the opioid crisis, right? So just the framework that we were doing the work in is important for you to understand, because it's going to impact how we do the work that we're doing now. Do a lot of youth violence. I mean, so you see the list here, a lot of mental health work, period. Everything we do is strength-based, protective factor informed. You'll see me say, or you'll hear us say trauma informed. That's really not the right framing, you guys. We have to change it from trauma informed to protective factor informed. We know that the trauma's there. What are the strengths? What are the protective factors? And a question I ask a lot is, are you a protective factor? That's the fundamental question you ultimately have to ask yourself. Are you an asset to the community or a liability? And so we're going to talk about how do you have a protective factor approach? How do you become a strength and an asset for the community as well? So we're going to get into that. Again, here are the audiences with the highest health disparities. We can go through that. Since about 2000, been working in a lot of rural white communities, particularly parallel to Carlton, focusing on the opioid epidemic. So we do a lot of work. There's a lot of things that, are different, obviously, primarily worldview, but there's a lot of things that are very much overlapped and in common. Particularly, again, just the prevention approach is what's going to be needed. We do work all around the country. It is ironic that being in Philadelphia for the last 30 years, I think I've done one keynote presentation in Delaware. I've never really done any work in Delaware. I'm busy in large, major urban markets or states that just have the highest health disparity. So obviously I do a lot of work in the South. In the South, you have the highest levels of poverty amongst Black people and communities of color. And you also have the highest levels of health disparities, but then in urban areas as well. So obviously I've been doing work here in Philadelphia with all of the health commissioners since the beginning of when I started my company, and then do a lot of work with the state and as well. But again, I can't say I've done a lot in Delaware. I actually I don't think I've done anything in Delaware. Anyway, I'm sorry about that.
We're changing that.
No, I was just trying to think while I was going through this. So listen, real quick, I always start off my presentations with the learnings, the takeaways that you'll hear me kind of go a little bit more detail on as we go through this. First one, we're doing health communications, health literacy. One of the things I always say that we have to really push back on very strongly in the prevention community is we have to understand that the reality is the lowest income communities, Black, white, Latino, LGBTQ, the lowest income communities aren't making uninformed choices, are making uninformed choices. The media tries to have us think they're making bad choices. What we find overwhelmingly when we look at health disparities is people are modeling behaviors, right? They're modeling what they see in their communities. They're modeling the behaviors of their parents. They're not making bad choices. They're making, in a sense, uninformed choices, because in many of these communities, particularly around substance abuse, you know, we have to have a different framing and give folks different information to reconsider their behavior. And we kind of say that a lot in prevention, but we actually have to start implementing it more. The second thing is, the number one reason why prevention efforts aren't successful is because, and we've done extensive research on this, the community always says, yeah, you think you're doing something, but you're not really talking to me. You're talking to me, but you're not talking with me, and you're not talking to how I view the world. So there's this notion I'm going to take you through called worldview. And it's important to understand that if you're not speaking to the worldview of the community that you're trying to do your prevention effort in, they're going to opt out of your message. They're going to just say, you're not talking to me, because you're discounting their reality and you're not talking to their social determinants of health. And I'll talk about how do you talk to the social determinants of health, so that then the community goes, oh, you didn't mention social determinants of health, but I know what you're talking about because this is what I'm dealing with. So we'll talk about that. The other thing is that not only are you not talking to me, when you do talk to them, or when we're able to get through to communities, most of our messages, which means our framing, is punitive, it's preachy, and it's deficit driven. It's not giving them doable messages to change their behavior. So as someone mentioned in the health library, it's what is the health literacy? How do I give them information that in a sense is health literacy to that group that can then take that information and do something with that message, right? Trust, I talk about this, you'll hear me talk about that again. There's trust issues with who is the sender of the message, and there's trust issues when they go to the locations that we're driving them to. So we have to understand trust. One of my mentors used to say it perfectly. He called it, actually, he used this phrase, he called it healthy suspicion. He says, actually what these communities have, it's a healthy suspicion. There's nothing wrong with it because it's how they're gonna cope with the repeated mistreatment. So you start becoming healthy, but you don't want to become paranoid. So you just are suspicious. And then, so he would always say, until you actually deliver on the promise, you're really not going to start dealing with trust, because it's delivering on the promise. We're going to talk about the model. We're going to talk about sender message channel receiver. Basically, if you go to any school of communication at the university or higher level academia, there's the whole notion of communications, and it's basically sender message channel receiver model. So I'm sure our librarian would know this, but it's what all communications follows a model. And so I want to kind of go through that so you guys can understand just the basic model of communication, and then how from a health literacy perspective, we flipped the model. But why did we flip the model? So we're going to take you through that. As Carlton and I both discuss and talk about, and probably preach, is, primary prevention is protective factors. So that's the content that we're trying to look at. And we're trying to say, how do we take a protective factor approach to being able to not only deal with substance misuse, but other disparities at the same time? And so these are the things I want to go through. Here's the flow. We're basically going to just use we're just going to basically go in reverse. So I'm going to the rest of the session is me explaining how we do health communication interventions. And so just a way for everyone to think of it. So I'll give you the framework. We'll talk about channels, why channels are important. Those are the ways that you're going to deliver your message. Talking about content, that's the messaging, and then who should be the sender of the message. And this is another thing that health departments and mental health departments at the state level and even county and local level don't understand. You might not be the best sender of the message. So it's identifying who is the best sender of the message if you really want to start doing prevention work. And then through our training portal, we're going to share a lot of resources, the slides, everything. But there's a number of other resources, handouts, research, publications, videos that you have access to when you go download the slides. Okay, so Carlton mentioned this, I'll go through this. You guys are familiar with the strategic prevention framework. This is just our take on how we do it. And we actually implement this all the time. So I can show you actual widespread adoption, as Carlton mentioned earlier. Just some recent work, we're working a lot. Basically, again, everything's in silos. That's part of the problem. So we're doing a lot of work, obviously, around opioids, but we're also doing a lot of tobacco work, totally different clients. So we find the opioid work isn't connected to the tobacco work. I don't understand why, but it isn't as much in many places that I work at, but this is just some of the stuff we're doing now. So here's the approach that we take on all of our projects. So I'm sharing just how we would go into so when Carlton and I work on projects together, this is just how we start. So I'm sharing how we start, how you should look at a project. Basically, any health communication project where we were saying, where's the audience at point A, where are we trying to drive them to? We go in again because it's high levels of poverty, low income, and the highest health disparities. We realize there's stress and trauma. So our position is how do we go into communities that we know have stress and trauma and therefore have unhealthy behaviors? How do you go and start trying to communicate with these communities in a way that you can move them from what we call point A to point B? So we're trying to go from stress and trauma to thriving, all right, making healthy choices. So and then we're going to talk about sender, message, channel, receiver. So this is the model that all communications goes through. There's a sender of the message. There's the message he or she is sending. There's the channel we're using to send the message. And then you're the receiver. We're in a workshop right now. That's what we're doing. And basically, all communications follow this model: sender, message, channel, receiver. For health communications, we flipped it. And we find that because we're doing behavior change in communities that have high health disparities, it's best to start with the receiver. So all projects, and with your projects, I'm really recommending just start with the receiver, and we'll talk about why, then go to the channel, then the message, then the sender. And believe me, what people don't realize is you're doing this right now. You actually may not realize you're doing this, but you're doing whatever the work you're doing in communities, you're doing sender, message, channel, receiver now. I want you to flip that and start with the receiver, channel, message, sender. And I can work with a lot of folks and show you how you're doing left to right, not right to left. So that's the first thing you should do is always start with the receiver. Then we're going to go to the channel, message, sender. So, think about why would we start with the receiver? And so I'm going to talk about that in two ways. We always start with the receiver because we have to understand that when we're going into communities with high health disparities, we have to understand how they view the world. We have to and I always try to get people to understand the concept of worldview. And so if you think about worldview, go think about when you're driving to a new town that you've never been into. You go down that main street and you see the town one way. Then you return, and then coming down the opposite way, because you're returning, you then see things that you didn't see before. I use that analogy is because what we do is when we go into communities, we have a worldview of the community. We see them a certain way, and that's going into the town. What we don't realize is that they're looking back at us as well, going back the other direction, and they have a different worldview, and they have a different worldview of us. So we start with the receiver always so we can understand how they view the world. And then the second thing we're going to talk about is the receiver's communications culture. This is back to the health literacy part. So we're going to talk about the two main communication cultures in the world. It, really have been around forever. We're going to talk about those two. Then we're going to go to the channel. So again, let's do critical thinking. Besides me just saying right to left, why would we go to the channel after the receiver? Well, we're going to get into this, but we always start with the receiver so we can understand their perspective on the issue. And then they're going to tell us what's the best channel to reach them. And then ultimately, because as an ad agency, I do this all the time, I develop different messages for different channels. But once you know what the channels are, you'll be able to develop the best culturally competent message for that channel. And then, as I said earlier, then you decide who's going to be the sender of the message. But you'd be surprised, everyone. We always tend to go into communities and we do left to right. And I can tell you a number of clients who I've worked with who go, okay, well, I'll tell you a quick example. And I'm not trying to, this isn't a disparaging comment because I love this organization, but I was working with the Carter Center, Jimmy Carter Center. We were doing early childhood development. And we're doing early childhood developing a campaign, a behavioral health education campaign for parents, low-income Black parents in urban communities. And when we're having this call here, the planning call to discuss point A to point B, their notion was, well, why don't we get Oprah? Because they thought that she would be the best sender of the message talking to low income Black women, right? And then the message was what to do around parenting. The channel was TV because, again, that was the channel that they thought was going to be the most, the most effective in reaching the receiver, which was low income parents. And they got it totally wrong. But I see this a lot because we're trained to think left or right. And so we go into communities, particularly when we have resources, we go in and say, okay, well, we have to get this done. So you go in and do something to a community, not with the community. So I'm going to take you guys through what we call the social. I refer to health disparities in a, CDC uses this term, the social determinants of health. I use the term the social determinants of health disparities because you're going to see that the social determinants have actually created the health disparities. And so you need to understand what's happening in communities. And so this is our model. Again, we're sharing it. But when I go into communities, so if I was going into work in Wilmington, and I know a little bit about Wilmington, but if I was to go in, I would look at these 8 variables to understand how the audience views the world. And I'll take you guys through this in a minute. But it's you have to understand that if you don't understand how they view the world and how they view the world through a number of lenses, you're not going to be able to really tailor your message that they go, oh, okay, you're speaking to me. And so we'll talk about that. So here's what I want to take you guys through in terms of the social determinants. And I use this phrase, and I don't say it lightly, and I'm not saying it to be mean or to be, attack anything. But what I've seen from my 30 years working in low income communities, both urban and rural, is the social determinants of health are so bad that failure is built in. I mean, we need to really just openly understand what's happening in some communities and then realize why you see these health disparities. So I really track this, and so I just want to take you guys through this slide real quick, just so you'll know the work I'm doing in Philadelphia and Baltimore, because I work in both cities right now around youth violence. Let me just give you a framing of what's happening right now in these cities. So in Southwest Philadelphia, the chances of a young person right now living between 15 and 24 are less than when my father served 2 tours of Vietnam. When you look at CDC morbidity and mortality data, that's how violent these communities are. Now, again, media presents this as a risk factor. Obviously, it's a risk factor, but you have to understand that it's about 10, no more than 15% of the kids, even in the lowest income parts of Wilmington, that are committing 80% of the violent acts and crimes. Most kids are navigating the street. They're just trying to move from point A to point B. Then the second thing is when they're navigating the streets, they go to these public schools and sometimes now charter schools. But what you need to understand is, and we've done this research, when kids go into schools, in urban schools, public education, they identify 3 types of teachers. Teachers genuinely concerned about them. They know who those teachers are. They know the teachers that are there for a paycheck. And they know the teachers that are not only there for a paycheck, they know the teachers that are afraid of them. And so you have to wonder, how are you going to teach someone if you're afraid of them, right? Poverty is the next thing we look at. And when we're talking about poverty, I always try to put this in, because people say, well, poverty in America is different than other countries. Well, yeah, it is. It's actually worse. Even though the income levels are higher, the poverty is much worse than like in Africa and other Asian countries, because they're not marketed to constantly in terms of consume. And it puts a lot of pressure to try to have stuff that you can't afford, but you're literally marketed to 24/7, because that's really where the consumerism is coming from. So you have to understand, the best quote I've heard on this: when you live in poverty, poverty makes you angry. And I think that really captures what's happening. But I always try to get people to understand poverty also just from a mental health perspective. Think about, and we'll talk about the disappearing village and how basically 70%, some cases 75, near 80% of low-income Black kids are born into single-parent households. But let's look at it a different way. If you're a single-parent mother right? And you're living in a low income community, and just as a way to frame poverty, and you can't get housing, right? Or you having, housing insecurities as a, that's the new phrase we want to use. But just think about just us on this call, how important it is every night to be able to lay your head down somewhere where you can really rest, because you're safe, and you can actually just drop the guard and drop your whole immune system for 8-9 hours. You got to understand that, poverty shows up in many ways, but it is trauma. Living in poverty, creates stress and trauma for folks. Public health, I talked about that. Again, I can go through all of the disparities, but the key thing that I find with public health is that, and I have to be honest, we saw the misstep this year of CDC on the pandemic. Public health doesn't mean just because you're public health that you're trusted. It's an issue of how people are treated in public and mental health services is the big issue I see. Government. So it's not our Carlton knows this, our work in Louisiana. Louisiana right now, everyone, in 2021 has the highest incarceration rate of any basically region in the world, including Russia. Louisiana does. They lock up Black people at 4 times the rate than South Africa did at the height of apartheid. That's right now. Apartheid was 30 years ago, and it was a legal racist system with a majority Black country. So you would assume there's going to be a lot of Black people locked up, but we do that at 4 times the rate here in Louisiana right now. But Louisiana is just it's the epicenter, but it's all over the United States. Incarceration has obviously been a major model for and a major source, let's put it this way, of health disparities, and this concept of failure is built in, right? Messages, we'll talk about as we go through this, how much messages and media is consumed, but it's negative media. It's not protective factor media. The content is low common denominator. It's sexist, racist, it's homophobic, it's deficit driven. So we have to understand that. Family, disappearing village, and this is both for urban and rural communities. When you find what's happening in the lower income areas of both urban and rural parts of our states, what you find is that you have, and really with poverty, you really have high levels, not only of unemployment, obviously, because that's why you have poverty, but you also have just the notion of large single parent households. What does that really mean? It means that you don't have what we call village. As folks probably know on this call, if you have kids, I know Carlton has some kids, I have a son. They're literally, if you're honest with yourself, there's no way you can raise a child by yourself. I mean, obviously some people do it. Black women do it all the time. So I'm not saying it's not done. But the best way to actually, if you think about it, you always want village. You want, even as a parent, you want the support. Like I put a lot of pressure on my brothers and sisters and my, his cousins, everyone to be involved, so that it's not just coming from me or his mom. That's how you actually really introduce a lot of the protective factor, positive coping skills that we talk about, is through this notion. So I never blame. So what I'm saying here, and I'm sorry for kind of digressing a little bit, but I never blame parents. I enable parenting, because what I understand with family and the disappearing village is that everyone needs enabling. And so it's about how do you create, and if the village is gone, then you're losing out on those social connectedness, those supports. And that in and of itself, as folks know, village social fabric is a protective factor. So if you're actually taking away the protective factor, right, then you're gonna increase health disparities. And then mainstream society, I'll really quickly go through our research that we borrow all the time from ABC. They haven't repeated this, but they used to repeat this research, but I can give you the sense of it because it's still in place right now. They would take a group of white kids and Black kids to a local kind of suburban urban mall that was accessible by both suburban and urban kids. And they would do a series of exercises. And the exercises they would give all the kids, first of all, they'd give all the kids $1 and say, go go amongst the local merchants and get change. And you'd see on camera, the white kids getting change for $1 and the black kids denied. Now we're talking about just an even exchange. And you would see just on those exercises, black kids getting turned down at much higher rates, right? Second exercise, they gave all the kids a purse and said, go amongst one of the local merchants, return the purse so hopefully it can get to its rightful owner. All the white kids returned their purse, were congratulated, appreciated. All the black kids were questioned, interrogated, or held for security. So you understand that this is when people talk about systemic racism, I don't think people were really consciously thinking they were being racist or mean or prejudiced. But if you just look at the numbers, it's just built in that way. So the example, the reason why I give folks that example is that we also say to those kids, and ABC didn't do this study, but they've done other similar studies with black men and white men, is go amongst the local merchants and get a job. And so if you do this, you'll see the black kids will go amongst the local merchants and they'll say, nope, don't have a job, come back another time. And when they really actually do the hiring, it's really when a white kid comes and then they go, oh, just your lucky day. We just have we have an opening. Oh man, good. And so you'll see how this plays out. What I try to tell people is, what does this mean about failure built in? Think about it. When we were all little, you put the hands on the stove once or twice. And after a while, you stop putting your hands on the stove because you're getting burned. So it's the notion of perseverance getting beat down. And so what I find in a lot of low income communities, we're always looking for motivation in people. And it's not that the motivation isn't there in some cases, it's just constant failure, constant disappointment. I remember working with a mentoring program, and they had this policy that they were doing great mentoring, they felt, and they had a lot of resources to go behind it, but kids have to maintain a C or better for all their grades to stay in the mentoring program. What about the kid that went from the F to the D, or the kid that really may have even went from a C to a D, but because of what may have been happening in their lives? So now all of a sudden you introduce another failure. So I try to get folks to understand the worldview of the audiences we're working in. So how does this show up now? And what I tell people, if you go back and forth, it's coping with stress and trauma. So some communities cope with it through self-medication of alcohol, tobacco, and other drugs, right? Some medicate with processed foods, sugar, salt, comfort foods. So we see literally an addiction to not only substances, but food as a substance, right? It is a substance, and there is addiction to some of this. And then you also see folks acting out with anger. And then the part that's not discussed a lot, probably within mental health though, is the whole notion of internalizing the stress. So again, the media is always going to just talk about, low income, urban and rural communities. They're self-medicating, they're violent. They're going to talk about the risk factors and the behaviors. They're not talking a lot about the majority of those communities, or really, because again, violence isn't a big group. Substance abuse is a much larger portion, but there's a lot of people who are just internalizing. And part of even substance abuse, as you know, is a way to internalize in and of itself. So there's sometimes, even with substance misuse, it has those different outcomes, external versus internal. But what I'm trying to get folks to understand is these are all learned behaviors. So people navigating this kind of social determinants of health disparities are coping with it in these kinds of ways. So once we understand that, then we can start developing our messages that look to that worldview. Here's the example I get, particularly around alcohol, tobacco, just as a way to, bring it home. As I said, Carlton and I have been working in substance abuse for, at least I have been, for the last 30 years. So early 90s, the first report that I put out, Reaching the Hip Hop Generation, funded by the Robert Johnson Foundation, looking at marijuana use, right, amongst low-income Black kids. Think about it. That's what we were doing. We were focusing on marijuana use amongst Black youth. Now, marijuana is definitely, medical marijuana is legal many places, if not marijuana use. But again, we were on the prevention side. So we were working with CSAP, we were working with Robert. So there were folks on the prevention side, but it was done within this framework of the war on drugs. All right. So what I want folks to understand is the first 20 years, and then my last 10 years. So my first 20 years was more focused in the war on drugs. I sat on the DCP's Behavior Health Council for almost 10 years. So I really have been steeped in both sides. And then obviously I've been doing a lot of work around the opioid crisis. But just look at the, again, worldview. This is understanding worldview and framing. So just look at this. How do we frame the war on drugs in terms of who the audience was? It was Black, it was brown, it was inner city. Maybe as long as they were Black, it could be rural, but it was Black and brown and inner city. It was people of color. The opioid crisis, you know, we understand was really framed as a way to help, you know, opioid abusers, mostly in white rural suburban areas. So look at what we refer to as the war on drugs. It was, you know, we're talking about heroin still, crack, we had some other stuff, but we still have all that on the opioid crisis as people move around different drugs, right? Heroin, crack, dope, we call it. We are clear to call it opioids and prescription pills on this side, all right? How is it framed in terms of who's distributing? Drug dealer, drug cartel, doctor prescribed pharma. The terminology, addict, crackhead, junkie. No, on the opioid crisis side, it's substance use disorder. We're clear that it's a disease, right? It's not, you're not a crackhead, you have a disease. On the war on drugs side, it was a criminal, again, Carlton and I worked on the prevention sides, Robert Johnson, health departments, CSAP. I never worked on the criminal justice side, never worked with the DEA, wouldn't work with those guys. But understand that that's really where the trillions of dollars were primarily coming through the criminal justice side. We're talking tens of trillions of dollars over this time period. And then on the opioid crisis, it's look at the main institution. It's medical, it's public health. So rightly so, it's coming through the right institution. So at least it's supposed to be an asset, not saying it is, but it's supposed to be an asset versus the criminal justice system, which we know is punitive and not an asset. So just think about that, just making sure it comes through the right institution, you know, crack houses, and then in Philly, we have safe injection sites. So, and then final is the overall framing. So we demonized, we locked up, incarcerated folks on the war on drugs. But on the opioid crisis, we're very clear to call it harm reduction. We want to help save. Now, listen, here's my point. We should have been doing the opioid crisis the last 30 years for all substances. So I'm not saying that we shouldn't be doing what we're doing on the left. I'm just saying we should have been doing it for low income audiences that were, poor Black and brown people for the last 30 years versus now really trying to do that. And now we wonder why these communities don't trust us. So now we may be even talking more from the opioid crisis framework, but am I going to believe you after 30 years on the war on drugs? So I just want folks to understand framing is critical, and we're going to show you how to do that. So the second part, you guys, of the receiver is, so we talked about worldview. The second part, when you're writing the notes, so the first thing you should put under the R is worldview. Second thing you should put under the R is communications culture. So one of the things you have to understand, and this deals with health literacy. This is the differentiator with I think our model around health literacy versus the traditional model on health literacy. So it'd be good to have a discussion, with the librarian around this. But one of the things I try to get folks to understand is that we're doing behavior change. Now, behavior change communications is different than consumer marketing. You have to understand consumer marketing is, I'm going to do Pepsi or Sprite. Behavior change marketing is, I'm going to wear a condom, not wear a condom, or I'm going to smoke weed, not smoke weed, whatever. So it's a harder proposition. It's much easier to do consumer marketing than behavior change marketing. Consumer marketing, you can use all of, we know people, one, are going to buy tennis shoes or drink soda. It's just trying to get them to do brand switching. Behavior switching is a much harder proposition. And by the way, as y'all know, you can't change someone's behavior. All you can do is give them the information to change their own behavior. So again, understanding health literacy and DiClementi's model of behavior change, if you go from pre-contemplation, contemplation, preparation on, you have to understand people have to have, from a health literacy perspective, have to have the information, cost benefits to change their behavior. So what we're saying though is that when we go into our communities that I do the work in, there's a big difference in terms of how they communicate then from the funding source. So what I try to get folks to understand is that there's oral-based culture and then there's literate-based culture. The funding source is literate-based culture. That means, and you guys know this, you want to do work around primary prevention, you write a grant, it has good evaluation, it has reporting, it has a lot of data collection. Hopefully it has IRB if necessary, maybe HIPAA compliant. We check all the boxes because we're speaking to a literate-based funding source. What I try to get people to understand is once you get the funding, you're going into communities that are oral-based. And what I mean by that is they subscribe to a different communications culture. So the culture we got the funding from is what we call a literate-based culture. The culture that we're going to do the implementation with is what we call an oral-based culture. So I want folks to understand that. And people always say, well, where's the literature review on the oral tradition? So that's how, they don't believe it unless it's written down. So if folks need the literature review on the oral tradition and oral communications culture and would like to put it in the library, for example, I would be more than happy to get it to you. So understand that. So now what does this mean though, in terms of behavior health? So the key thing I try to get people to understand is at the root level, your communication culture defines primarily how your history is passed down. So if you come from a literate-based culture, that means your culture primarily passes down their history through the written word, right? So you've been, written stories, literature, you write it down, that becomes how history is passed on. In the oral tradition, history is passed on through storytelling. And what I try to get folks to understand is that that's actually a little bit more complex because you're not writing it down. And so you just can't go. So if you think about stories that are passed down accurately from generations to generations for hundreds of years, it's because there's some rules to how that communication takes place. And so we're going to talk about this, but that under that are, so you should have worldview, now you should have oral culture. There's 3 rules of oral culture that I want you to write down so that you can then understand why it's important to understand that when we're going in and doing these interventions, we're going into an oral-based culture. First rule in the oral tradition is that the receiver of the message, remember, we're back to this now. The receiver of the message has the right to challenge the sender. So the first rule in the oral tradition is that, okay, if you want me to reconsider my behavior and make a different choice, I have the right to challenge you. So think about it. It makes sense if you understand the oral tradition, but people don't get this because we're coming at it from a literate-based approach. And we're sitting there going, okay, I'm the sender of the message and I have the literature and I have the expertise and I have the science. You don't challenge me. That's literate-based culture. The receiver doesn't challenge the sender of the message. But in oral-based culture, the receiver challenges the sender. Right? So it's important to understand that. And we'll talk about why, but think about it. Why would I have the right to challenge the sender of the message who supposedly has this information? So I'm trying to get you guys to understand that that's the first rule in the oral tradition. The second rule is the receiver of the message is going to challenge you with an argument. Remember, I talked about De Clementi's model behavior change. Argument is the equivalent of the cost of changing my behavior. We're going to talk about counter argument in a minute, and that's the equivalent of the benefit to changing my behavior. So in the oral tradition, the receiver has the right to challenge the sender. They're going to challenge the sender with an argument on why. So you want me to, carry Noxolon, this is why I'm not going to do it, because if I have it on me, then, and I get stopped, they're going to think I'm using. That's because I'm poor, I'm Black, so you got to understand that no matter what the behavior changes, and we'll give you some examples, the community is always going to think, one, I have the right to challenge you, and I'm going to challenge you with the arguments. And then the third part is, do you have a persuasive counter argument? Let me just show you an example real quick. It may be easier to do it this way. So let's go back to, again, I'm a little biased. I don't do marijuana work anymore. I did it for 20 years, right? So the last 10 years, I really, thank goodness, I haven't really done a lot of marijuana, even though I do have an opinion on underage use of marijuana. But, no one's doing marijuana prevention anymore. I don't know. Maybe Carlton is, but we're not. But the point is what did we learn about marijuana? So if you work with young people, you go into any community, probably most various communities, Black, white, Latinx, LGBTQ, African immigrant, marginalized. When you go into the community and you ask them, why do they smoke marijuana? What they perceive are the benefits, right, to smoking marijuana. Now you're trying to change this, but these are what they see as the benefits. So they would refer to them as an argument. So the first one is it's cool. And what I always try to get folks to do is, one, if you understand the worldview of the community, you'd know these arguments, because now you understand how they view the world and why these are their arguments. But the second thing I want you to understand is that it's most folks don't know the arguments, and therefore, if you don't even know the arguments, you can't develop persuasive counter arguments. So in the oral tradition, it's argument, counter argument. That's the equivalent of cost benefit, right? So it's cool. Second one, it's not addictive. So what's your counter argument to it's cool? What would be your counter? So if you're engaging in a behavior change dialogue with a young person, and they would say to you, oh man, I smoke because it's cool. What would be your counter? Then it's not addictive. Oh, it's not addictive. I've never seen anyone overdose from marijuana. What's your counter? It makes me creative. I'm an up and coming artist in the community. And so it makes me creative, and, I can write better lyrics. Counter your argument. It's an escape. Remember, I showed you guys the social determinants of health. So it's an escape. It's an escape from the reality. It's an escape from failure is built in. Then, which I heard for the first 20 years, it should be legalized. Guess what? That was a big argument. Young people were like, oh man, this should be legalized in the first place. It shouldn't even be illegal. Back then, what was your counter? My friends and family all do it. This is obviously with many substances. My friends and family all do it. So this is a learned behavior. I see them dealing with stress, and this is how they deal with it. And it's natural, it's healthy and natural. One of the reasons why it became legal. It's healthy and natural. So understand that. And then you go further. What happens when young people say, which is an argument, I didn't put it on there because I wanted to just talk about it. At the end of this, you could have great counter arguments to each of those. And then a young person will finally go these last two arguments, which is, but I'm in control. I'm in control. I'm in control. Marijuana isn't addictive. I'm in control. And that's another argument. And then the counter to that one is, well, if you're in control, then can you stop for a week? Can you stop for 3 days? And then because you're in control. You're in control. So let's just chill for 3 days. Come back. Let me know if you're in control. And we would see, because we actually worked with treatment providers, and that's exactly was a very persuasive one. But then there's the ultimate argument, which is I don't care. And you get that again, based on the social determinants. What's your counter argument to I don't care anymore? I just don't care. So I'm smoking because I don't care, which again is for a lot of people from their perspective, a legitimate argument. What's your counter argument? So this is my point, is that the key thing you need to understand is when we're doing interventions, you have to understand the worldview of the audience, and you have to understand their communications culture, their form of health literacy. So some people we may want to call it health oral communications culture instead of health literacy, right? So we have to understand that we gotta go into communities differently. And by the way, this is very prevalent in the lowest income communities, even in white communities, because again, you have low literacy levels, and so they tend to rely more on oral tradition as well. Not in the tradition of passing down their stories, but in terms of how behavior change works. So it's not just the oral tradition in terms of I want you guys to understand that I was giving you how stories are passed down so that you could understand the link between that and behavior change. And the clear link is very much this. For stories to be passed down, so I'm passing down a story that I heard from my grandma. And my grandma used to tell me some stories. And I would always say, why is she telling me this? Why is my grandma talking to an 8-year-old and telling me these, from her perspective, very, very important seeds that she wanted to implant? And she actually planted them. But my point is when you do that, you have to understand that if you're going to do storytelling and you're told a story as a child, and then you're the grandparent and you're telling the story, you understand that it's done in a social context. So me challenging the center of the message means that I have to go back and forth with you to get this information, this detail. So I have to be able to challenge you. I have to be able to question you. I have to be able to ask more or need more. So it's that social, when I say you're challenged, it's in the social context of us having a relationship. The best interventions that we see work around the strategic prevention framework are based on creating relationships with the community. And what I try to get folks to understand is understanding the oral tradition is your link to being able to develop real relationships with the community, because you're saying to the community, I'm open to being challenged, right? I'm open to being challenged because I want to have a relationship with you, so that then as you engage me with arguments, I can then counter with persuasive counter arguments. So that's what you're really trying to do, but you're doing it in the context of behavior change. So think about storytelling again. Stories passed down for hundreds of years, that it goes back and forth. And I'm able to have this social interaction to get the details, so that when I become the grandparent, I want that child to challenge me in the sense of argument, counter argument. So then I can share those, the rich details of the story in a way that then they'll remember it. All right, because you're not just going to remember by reading it once. It's engaging in the banter, in the debate, in the dialogue that enables you to see if the story is going to hold up over time. So that's important for folks to understand. Now, in behavior change, is important to understand because there's 3 reasons. If you're not engaging in the oral tradition in an effective way, again, the community is going to say you're not speaking to me. Let me just give you a quick example from a public health and mental health perspective. If you're relying on transit ads or giving the community brochures or printed materials, that's taking the wrong approach. That's taking a literate-based approach with an oral-based culture, right? You see what I'm saying? Because what you're doing is you're thinking, I can give them the brochure, I can give them the website, I can give them the social media, and they'll go change your behavior. It doesn't happen that way, because behavior change happens in a social context. So I have to be able to, 1, make sure that I understand the oral tradition, 1, because they'll opt out of the message. 2, I'm not going to get them to make an informed choice because I haven't done argument, counter argument. I haven't done cost benefit. So when you actually engage the community in the dialogue in and of itself, which is what I'm going to show you how to do, then you're actually engaging in these discussions around making a different choice, making an informed choice around a particular issue. And then 3rd, which is the key part, if I do it well, so if I was to do argument, counter argument with Carlton on a topic and we go back and forth, I would know that I'm successful is if then when Carlton leaves our discussion, he has that same new counter argument and he's sharing it. So when we talk about word of mouth in the community, how we make messages shareable, I have to give Carlton, I have to let Carlton engage me in argument, counter argument, to the point where then he goes, okay, I'm going to take that out and test it almost with my friends and family, my peers, my community, my constituents. Think about it. Why? Because the exact same arguments Carlton just gave me are the exact same arguments Carlton's going to get from the community. He just brought those arguments in because he's coming from the worldview where those arguments were shaped. So I try to get folks to understand that it's critical from the work that we're trying to do is to understand the receiver of the message first and foremost, and then understand his or her communications culture. This is how you're going to be able to start putting in different kinds of messages that are prevention oriented, that are protective factor oriented, and that deal with multiple health disparities. So let me pause there, Carlton, for a quick second and just see where we're at on the time so I can calibrate how to go through the rest of these slides, even though everyone's going to get all the slides.
We have about 15 minutes.
Okay, so let me move forward then, you guys. So now remember, I said right to left. So now we're going to go to the channel. Remember, right to left. And so people always say, well, again, you know, what's the best channel to send the messages? We haven't developed the final message yet. We're going to talk about what the message should be, but we still need to know from the receiver what's the best channels to reach him or her. So we track all this. We understand all the various communications channels, traditional media, digital, social media. We understand how low-income communities interact with digital sites and social media, print material, And then we have these other ones at the bottom that I want hopefully you guys to take notice of, which is we also say as a channel, we do community outreach. And we also work with peer educators. And people say, well, that's a channel? Yes, it's a channel. It's a way to deliver the message using the receiver themselves as the channel. And you're using a receiver themselves as a channel that comes from the oral tradition, so that you're actually getting two benefits. So understand that we're going to focus on that. So this is, I put this up and I'm serious. Many of my clients still think this is the way to do community outreach. And so they focus on social media and they focus on some digital tools because, you know, it's easy for us to do that. We want the analytics, we want the data. But here's what we see over and over again is that, are you truly engaged with community service? If you're just putting up a social media page, you're taking a literate-based approach to an oral-based culture. And so it's not, ultimately you'll have a media page up there, but it's not going to be effective. So what I want folks to understand is that we track all this, and real simply, what I want everyone to understand, remember I talked about there's consumer marketing versus behavior change marketing. We're doing behavior change marketing. And so what we understand is that the best channels for behavior change marketing, or yes, we do stuff on digital because that's where our audiences spend the most time. But peers have the most influence, and adults / community power. Remember I talked about village, social fabric. It still has the most power. Intergenerational, really community power is really the best way to do behavior change, but we'll talk about that. So here's what I want you to understand. So now when we're doing behavior change, we're choosing the right channel for the right reason. I'm choosing digital channels just because I want to make sure I reach the audience because I know they spend a lot of time on digital, but I'm not using that to do the behavior change. I'm just using that to start the conversation. The second part is I'm using peers because peers have the most influence. And then ultimately I'm mobilizing the community because the community has the most power. And as providers and as funders and as institutional agencies, every client I say I tell them you should be mobilizing community. You should be doing active community engagement as a way to address primary prevention and multiple health disparities. So real quick on the channel part, because I got to move a little faster. It's just this notion, you guys, I try to get folks to understand. We just talked about oral culture. What I try to get folks to understand is online, there's two parts that you need to have. You need to have technology. Technology, what we say, gets you scale. It gets you reach, right? Because they're on technology. They're using it. I always tell people they're not using it for behavior change necessarily. People use social media for social reasons. And so that's why it's called social media. And people are like, well, we can just use social media to do that. Not to do behavior change. You can use social media to reach them, to maybe start a conversation. It's going to get you what we call scale or reach. But humanology, it's the community engagement part because it's an oral-based culture is what's going to get you impact. It's about ultimately how do you develop a relationship with the community? And the only way you're going to develop a real relationship with the community is to do community engagement so you can actually have the dialogue necessary to engage the community in behavior change. I know I'm going fast, folks, but I'm hoping this is making sense, but it's just a different approach to trying to do our health disparities work. It's a different approach to understand it. And I can take you through the exact hows, but you have to understand the why first. This is the why we do it. We can always do the how part, but you have to understand why. Otherwise, you won't do the how part correctly. You won't do it like academia says with the fidelity of the model. But just understanding this is how we go in. This is how we do work. And I'm sharing it with you. You don't have to use me production. I'm just sharing with you how we approach it so that hopefully you can think about a different approach to primary prevention, to protective factor, to substance misuse. Okay, so here's a quick example. We're doing the quit line for the state of Louisiana. So we manage the quit line and it's quit with us, Louisiana. So again, this is an example of the behavior. This is a behavioral health intervention we're doing right now. Again, these are all in your slide. So what we show them is all the things we're doing online with the community. We're trying to get the community to order a quit kit. We put stories on the internet, on social media, so we can give them tips and stories, the narrative, the oral culture for folks who have quit from their communities that look like them. We have videos that just promote resiliency and positive coping. We have we try to promote live digital peer support, but then offline in the community, look what we're doing. We're actually working and making sure that there are actual classes at the parish level. In Louisiana, parish is a county. So are they doing, and then are there real in-person male support groups? Because we know males get different supports than women. So all of this is the kind of stuff, but again, it's just a notion of online, offline. We're going back and forth so that we can have a relationship with the community. So community built, so even though I'm saying community, and I'm saying community mobilization, you still have to build trust with the community. So I'm excited about doing community engagement, but it's not like I think, just for an example, as an African-American, I could go into Wilmington and think just because I'm Black, I have credibility. It doesn't work like that. When you're doing community engagement, you go through the gatekeepers, you go through what I call the community identified leaders and the community-based organizations, faith-based institutions, places that they trust. It's not who you trust, it's who they trust. So we're always saying when we want to do this, but you have to build trust with the community through people that they do trust. So why community engagement is critical, and I'll wrap up here with a few final comments. You know, we do this because we're engaging a community, you guys, that has what I call healthy suspicion, right? But at the same time, we're addressing risky behaviors, and we have to do that through dialogue. So I have to do the community engagement, not only because of the trust issue, but I'm not only trying to deal with trust, I'm trying to deal with trust and have a dialogue. And this is the best way to do that. Ultimately, if I do it this way, then the messages are reinforced by the folks that I've been working with. And it's really through this engagement, this relationship, this dialogue, this argument, counter-argument process that we can really start changing behavior. So that's really the.
You're muted, Ivan. Ivan, you're muted.
Hit the wrong button. Sorry about that. So this is all in the write-up, you guys. I'm just showing that you'll get this on some of the handouts. So it's, again, the why we do community engagement. So if you can, when you get this, you'll see that there's what we call an operational win, a social responsible win, and a capacity building win. But what I always tell folks is, yes, you're going to get a win, but the only way community engagement really works is if the community gets a win. So this handout talks about how you get a win and how because they're not going to keep on engaging with you unless they get a win out of this, which is obviously the right thing to do. So you have to understand that the community has to get a win in terms of community engagement. Last few slides, you guys, I kind of talked about this. Everything we do now in the notion of argument, counter argument is how do we counter negative coping with positive coping? So this is the protective factor work that we're doing. So as I deal with substance misuse, I'm really trying, and I'm working in communities around the country to say, what are the skills that the community needs to have, the self-care skills to be able to deal with stress and trauma in a moment? So when someone said they're on the crisis response, but it's one thing to actually have a crisis response team. It's another thing to educate the community to actually have the protective factors, the self-care skills themselves to be able to deal with stress and trauma in the moment. So we have a whole process on how we're doing that. Practicing wellness. One of our mentors, Dr. Joseph White, used to always say, when you feel good about yourself, you don't have to beat up on folks. You don't have to engage in substance misuse because you feel good about yourself, right? So the whole notion of practicing wellness. Now, if I was talking to, and I'm just being candid on the call here because I'm hoping we all can talk freely and candidly. This is what's going on in white middle income communities all the time right now, is this notion of self-care and practice. This is common framing. This is common, but we don't want to have that dialogue in low income communities for some reason. We want to tend to have this deficit risk factor approach versus talking about protective factors. And then the last part I want folks to understand in terms of content, what we're seeing in our work is about 15% of communities, lowest income communities in the country, are actually thriving in the worst communities. What are these thriving skills that they have that enable them already at an organic 15% make different choices? Same social determinants of health disparities, which shows you that something is happening in communities where you're seeing 15% of the community members thriving. So how do we do that? And then how do we take it from 15% to you guys taking it to 55%, right? Connectedness to caring adults is a positive coping. We talked about that. And then we do a lot of linkages to trauma-informed services. This really should be edited, say linkages to vetted. The community needs to vet these services. We do a lot of what we call unannounced community audits, where we send the community to services and have them report back on how they're treated. Because how they're treated when they go there unannounced, right, is the way that it's going to really happen. So we can do a campaign and all of a sudden everyone knows that low-income communities are going to come for services. So we kind of, you know, we clean up our house a little bit. We want to know how they're treated when the house isn't clean, right? So the linkages to vetted services. So I just want you guys to understand that. Now, the key thing with this, and SAMHSA says this, you guys, the key thing I want you to understand is if we put in protective factors, the science, the mental health science clearly shows that if you teach protective factors, some folks will have no mental illness disorders. They've seen this in tours of duty, in war zones where, again, 15 to 20% of soldiers come back with no mental illness disorders because they went there with protective factors. And then the second thing the science clearly shows is if you have protective factors, you recover faster from trauma. And then again, as we know, some folks will need treatment, but how do we start getting upstream where we start seeing communities shift in terms of their wellness factor? And again, I just want folks, it's under the portal. We have all of the science on this. This isn't new science. David Satcher in 2001 said risk factors are not predictive factors because of protective factors. SAMHSA has put out the risk and protective factor model across the life. That's been around, but we're not doing it. So why aren't we doing it? I always say, why aren't we doing something that the science clearly, this is like putting on a mask, you guys. This is that level. Why aren't we putting a mask on the community to be able to deal with their social determinants of health disparities so that they don't have not only COVID, but they don't have the flu, and then they don't have a cold, and their asthma is down, and their allergies are down. You see what I'm saying? We have to, this is a protective factor approach. And I don't have time, but I just want to kind of summarize by saying, again, if we take this approach, community engagement, worldview, understanding that we have to have a relationship with the community, and then we start putting in protective factor content, then you start addressing all types of disparities. And I'm not talking just these. You can add risky sex. You can add COVID to this. You can add chronic diseases. You can add depression. So what I want folks to understand is if we really wanted to work in communities and have a different relationship with them, we can get upstream on some of this stuff. So again, I just wanted to end by saying, here's the content. This is the messaging that we're doing. What we teach 3 pillars of content. What to do in the moment of a crisis. This is a protective factor. If in that moment of the crisis, I know how to take some self-care, then I may not go to the pipe, or I may not go to the needle. I may go to something else, because in the moment, I'm being conscious. I'm pausing. I'm breathing. I'm taking a step back. I'm getting to a safe place. Wellness practices is what am I doing on a daily basis? So what am I doing to feel good about myself? Mind, body, and soul. This is mind, body, and soul stuff. So that, again, I'm looking at the world differently, and as stress and trauma hits me, I'm inoculated from it. This is the inoculation part. And then having a plan. These are the communities that we're actually seeing thriving. I'll just tell you guys, because this is based on national research. Black girls have plans way more than Black boys. And so Black girls are able to deal with stress and trauma differently than Black boys. I have a Black boy, I know this. Black girls have plans, Black boys are rudderless in general. Now think about what that means in terms of stress and trauma. If you have a plan, the science clearly shows that you don't catastrophize. If you catastrophize, it's the catastrophization that actually creates the mental illness disorder. If I handled it differently and it rolled off my back because I have a plan and a plan B, then I keep moving it. But if I'm rudderless like my son and stress and trauma hits me, then I think the universe is coming at me. So then I catastrophize. And so then I actually have the mental illness disorders. Having a plan, Black girls have a plan for today, for this week, for their school year, for prom, for their careers, and they have plans for their boyfriends that they don't even know about. They got plans for them too. Their boys don't have plans. The girls have the plans for them. But I'm trying to get y'all to understand it's a protective factor. And these kids and what we found is the boys that do have a plan do way more better with stress and trauma than boys that don't. Because we now have tracked the boys that have the plans and we see what they're doing. Now, they don't use none of this terminology. It's a whole different language. But the point is to understand these are the protective factors. And as bad as it is in 2021, and it's been the last 4 years, one of the things, again, my mentor, Dr. Joseph White, said protective factors had to be in place to come out of slavery. It's not as bad as it is even during slavery right now. As bad as it is what I'm saying. But Black people had thriving resiliency skills. Dr. White uses this term, stronger in the broken places. He's actually saying you're stronger than you were before because you're stronger in the broken places, because now you've been able to get back from a setback, and now you're stronger than you even were before. So understand, this is where I think we should be going with, with substance misuse, is understanding that we're not discounting their reality. We're actually acknowledging their reality. And we're saying, understand that we agree failure is built in, but you still have a choice. You can choose negatively, you can cope negatively, or you can cope. I'm trying to figure out, how do we put in those positive coping skills so that the community can then move forward? And remember, if you do it that way, the skills stay in the community. They're not connected just to us as the funder or the grantee or the institution. You're actually rebuild, and one of the protective factors is rebuilding village. Community engagement is your activation of the rebuilding village process, because you're saying, I want to have a relationship and I want to use community engagement as a way to start creating social fabric. So listen, I appreciate it. I hope this was helpful. I couldn't get to all the slides, obviously, but they're there. And I'm more than with Carlton's coordination, I'm more than happy to either finish later on, Carlton, if you want me to, if folks want me to, or whatever but you have it all in the slides. And again, if you just go right to left, you'll see the slides continue to go right to left. And so I get a little bit more into the messaging, and then I come back to why community mobilization. So you have all the detail on why community mobilization, and it's important just to read those slides, because don't get to the how until you understand the why. When you understand the why, then the how works. Thanks, Carlton.
Ivan, thank you, my friend. If you could stop sharing your screen right now, we can bring everybody back up. We have just a couple of minutes or so to make sure that we're in on time. Folks, before we do anything, could you help me in showing our appreciation in whichever way you find? You can just give an applause or whatever, but I just want to really appreciate Ivan for just a wonderful presentation and a journey that he took us on. This is all part of a conversation that Ivan and I have been trying to have across the nation. We wanted to make sure that we were able to bring it to Delaware as well for all the work that you guys are doing. We have just a couple of moments if you're wanting to, but if I want to just see if there's any question that somebody might have. If you show up and raise your hand, we can deal with one or two. And then Joe, if you have some closing remarks, thank you so much for being here. I appreciate your support with respect to this. And then we'll close out. But are there any questions first and foremost for Ivan while we have a couple of moments? Anyone at all? This typically happens, Ivan.
No, I'm good. I understand.
We do.
They're like, okay, that's enough.
They're processing. They're like, what? I got it. But it's all good. It's all good. If there are no questions, and because we are indeed up on time, I am so grateful, because what we're trying to do is we're trying to take this conversation and connect it to our primary prevention work and efforts. If we're going to be effective in applying our public health model, we have to assure that that public health model is adopted broadly. And if we do that, we need some of the tools, I believe, that Ivan is bringing and has brought to us. And so wanting to make sure that we have that conversation. So with that, I'm going to actually turn it over. Joe, if you have any closing remarks on behalf of DSAM, our supporter and sponsor with respect to this, and we will, Dave, if you don't mind, Dave, if you can put in the chat the evaluation link, and I'm going to implore everyone, please go to the evaluation. It'll take 5 minutes of your time, but please do that. It's important for us and for our reporting back to DSAM, but please do that. It has been our privilege and our pleasure to be a part of bringing this series to you and your state. Joe, I'm going to let you have the last words, and thank you again for your help and your support in this.
Thank you, Carlton, and I appreciate that. I apologize, first of all, that I entered late because I missed what I have interpreted to be a very informational and important message, I think. Thank you, Ivan. I appreciate it. This is the first time I've seen anyone present like this, and I've been around a long time. So thank you for this message. I think it's very informative. It reminds me of grant evaluations. I mean, I review grant applications all the time and have throughout my career, and your message is exactly it. You've got to find out how the people want to be informed. What is their culture? What is the way they live? How do they receive information? You can't just, it amazes me the number of grant applications I've reviewed in the years that says, oh, we're going to take this program and we're going to throw it at these people. And, they're going to do great things because we mean well. And it doesn't work. And I've been doing this a long time. So I think it's a great message. I hope we can learn more. I hope we can do this again. If not right now, maybe, 6 months from now, do this again, maybe a little bit more pre-planning and get a larger attendance, especially if we can get, some community leaders to come in on this and maybe start, make some influential, distribution of the training. And I think it'll be a fantastic opportunity. But again, thank you very much. And I apologize for coming in late. That's all I've got really for now. And like I said, I appreciate all the efforts you're putting in.
Thank you, Joe. Yvonne, any conversation, any comments from the kids department and all the partnering that we've been able to do with respect to this?
I just thought it was a great presentation, right to left. That made right to left. I mean, that made a lot of sense. Yeah. And as I think of media literacy and Carlton, if we think about I work on the block grant side, the information dissemination strategy, and making sure that we look at this presentation as we're out there doing those 6 CSAT strategies around media, because we do a lot around public service announcements. We do a lot of work now on Facebook, Instagram. So it really, the messaging, I mean, it was just spot on. But that right to left, yeah, on a Friday, that was perfect, right to left. So yeah, so thank you, Ivan, just for your presentation.
Thank you, Yvonne. Thank you, Joe, and Maddie. Thank you all for your great support with respect to this. My great thanks to my partner in these endeavors, Dave Clausen, for the remarkable support that he's provided behind the scenes, and to each and every one of you for all the remarkable work that you're doing on behalf of the state, where you all are. It is our great privilege to be able to be and play some smart part in supporting those efforts. We hope you find these of value to you, and we will be in constant contact. There is the evaluation link, hopefully, that you all will get. You'll get an email from me as well, reminding you about that evaluation link, but also we will have this recording up, and I'm going to provide that information to Joe, and we'll make sure that you all have access to the recording of this so that you might be able to access it for your team members that were not able to join us today. But with that, we've gone just a teeny bit over time, and I hate doing that. God bless you all. Thank you all so very much, and I look forward to being with you in the future. God bless. Thank you all very much. Take care.
Thanks again. Have a great weekend.
Thanks, Ivan.
Thank you.
Thanks, everyone. Thanks, Carlton.
Thank you. It was great.
You're welcome. Thank you.
Carlton. Thank you very much.
Take care.